How do healthcare providers interpret PSA testing results? When it comes to interpreting prostate-specific antigen testing results, healthcare providers take a thoughtful approach. They consider various factors, including the patient's age, prostate size, risk factors, and clinical history. PSA is a protein made by prostate cells, and while elevated levels can suggest prostate cancer, they can also indicate benign conditions like prostatitis or benign prostatic hyperplasia, often referred to as BPH. First, let's talk about age-specific PSA level thresholds. As men age, PSA levels tend to rise naturally. For men in their 40s and 50s, a PSA level greater than about 2.5 nanograms per milliliter is often seen as abnormal. The typical median PSA for this age group is around 0.6 to 0.7 nanograms per milliliter. For men in their 60s, a PSA level above 4.0 nanograms per milliliter is considered abnormal, with normal levels usually between 1.0 and 1.5 nanograms per milliliter. Providers may adjust these thresholds based on specific guidelines and individual patient circumstances. Next, let's explore how providers categorize PSA levels. A PSA level of less than 1 nanogram per milliliter is generally seen as benign, particularly in men at average risk. Levels between 1 and 3 nanograms per milliliter are usually safe, but men at higher risk may need closer monitoring. If the PSA is above 3 nanograms per milliliter, further evaluation may be necessary, while levels between 4 and 10 nanograms per milliliter are considered borderline and typically prompt additional testing and discussion. Levels above 10 nanograms per milliliter are significantly elevated and often lead to more urgent follow-up. Healthcare providers also pay attention to PSA trends over time, known as PSA velocity. A rise greater than 0.35 nanograms per milliliter within a year might be viewed as concerning, suggesting the need for further evaluation. If an initial PSA test shows elevated results, providers usually repeat the test after 6 to 8 weeks to confirm the findings. This is important because PSA levels can fluctuate due to infections, inflammation, recent ejaculation, or even vigorous exercise. If PSA levels remains elevated, additional diagnostic steps may include a digital rectal exam to check for prostate abnormalities, newer biomarker tests, or imaging like prostate magnetic resonance imaging to assess cancer risk. In some cases, a prostate biopsy may be necessary to confirm a cancer diagnosis. An essential aspect of interpreting PSA results is shared decision-making. Healthcare providers discuss the benefits and risks of PSA testing with patients, including the potential for false positives and the risk of overdiagnosis. Factors such as age, family history, race, overall health, and personal preferences are considered when deciding on screening and follow-up strategies. Lastly, medications can also influence PSA levels. For example, drugs like finasteride or dutasteride, often used for BPH, can lower PSA levels, so providers take this into account when interpreting results. Non-cancer causes of elevated PSA, such as prostatitis or recent medical procedures, are also considered. In summary, healthcare providers interpret PSA test results by using age-specific reference ranges, evaluating PSA trends, confirming elevated results, and involving patients in decisions about further testing or treatment. While PSA testing is a valuable tool for assessing prostate cancer risk, it is not diagnostic on its own, and a definitive diagnosis requires a biopsy. This careful approach helps balance the need for early cancer detection with the goal of minimizing unnecessary procedures and anxiety.